So today we're going to talk about the upper limb anatomy for the FRCR Part 1 anatomy exam. The first bone we'll talk about is the clavicle. The clavicle is divided into three. You have the proximal, middle, and distal thirds. The sternal end articulates with the sternum at the sternoclavicular joint, and there are several ligaments here. You probably don't need to know them, but if they're going to ask you one, it'll probably be the costoclavicular ligament, which joins the proximal clavicle and the first rib. Distally, you have the acromial end, which articulates with the acromial process of the scapula at the acromioclavicular joint, which you can partly see here. The scapula itself has a couple of processes. You've got the acromion process, which articulates with the clavicle, and you've got the coracoid process as well. The coracoid process is the most anterior part of the scapula, and it's a good reference when looking at shoulder x-rays and MRIs, as it's the most anterior part. You can then orientate yourself. The acromion articulates with the clavicle, and there's a ligament that goes between the coracoid and the acromion as well. The scapula also has several fossae. This is an anterior view, and the subscapular fossa is where the subscapularis muscle lies. You then have the posterior view, and you have the supraspinatus fossa and infraspinatus fossa, where the respective muscles also lie. You then have the glenoid fossa as well, and this is where the humeral head articulates. This is the humerus. You've got the red bit, which is the humeral head. Just behind that, between the humeral head and the greater tuberosity, you've got the anatomical neck. This can be quite confusing, and they can try and trick you in the exam by by pointing at the anatomical neck, and you have to say anatomical neck and not the surgical neck, which can be quite confusing. The surgical neck is at the metadiaphysis, and this is where the majority of fractures occur, often in elderly patients who've had a fall and fallen on their shoulder. You then have the lesser and greater tuberosities. The supraspinatus, infraspinatus, and teres minor tendons attach to the greater tuberosity, and the subscapularis tendon attaches to the lesser tuberosity. Between the two, you have something called the intertubercular groove, where the long head of the biceps tendon sits. The long head of the biceps tendon extends or originates from the glenoid labrum and then extends intra-articularly and then into the intertubercular groove, and that's why this is important. You then have the distal humerus, where there are articulations that form the elbow joint, which we'll talk about later on in the lecture. You have several ligaments around the shoulder. They might ask you about these, but if they're going to, they'll probably point at this one because it's the most distinguishable. This is the coracoacromial ligament, and that connects the coracoid process and the acromion. This can be thickened, and there can be inflammation around this in adhesive capsulitis. You then have the coracoclavicular ligament, which I doubt they'll show you, and then you've also got the coracohumeral ligament, which again I doubt they'll show you, but that helps to stabilize the long head of the biceps tendon, which is this structure in the intertubercular groove. You have several glenohumeral ligaments, which I don't think they're going to ask you about, and those are often part of the joint capsule itself. This is a schematic of the glenohumeral joint. The humerus has been removed here, and essentially you've got the glenoid fossa. Around the glenoid fossa, to help deepen it and improve the stability of the shoulder, you've got the glenoid labrum. You then have the coracoacromial ligament between the coracoid process and the acromion, and then you have several glenohumeral ligaments. You've got the superior, middle, and inferior glenohumeral ligaments, and I don't think you'll need to know these for the Part 1 exam. Let's go through an X-ray. This is an AP view of the shoulder. This bone here is the clavicle. This is the acromion, and so the joint between the two is your acromioclavicular joint. 10, projecting almost through the screen, would be the coracoid process. 6 would therefore be the humerus. 7 would be the glenoid. 6 would be the humeral head, and then just posterior to it, you would have the anatomical neck of the humerus, and then 4 would be the surgical neck of the humerus. 2 is the greater tuberosity. It's quite obvious, this bump here, and that's where several of the rotator cuff tendons attach. 3 would be your lesser tuberosity. And you might be wondering, what is this actually pointing to? It's pointing to this little ridge here, and they'll put an arrow to this in the exam if this is what they show you, and you'll need to know that it's the lesser tuberosity, and you're just catching it en face, and so it doesn't project out into anything. All you can see is this sclerotic line here. And then between the lesser tuberosity and the greater tuberosity, you'd have your intertubercular groove, which they won't show you on an X-ray. These are several of the muscles which I've mentioned. This is a posterior view of the shoulder, and you've got your supraspinatus in the supraspinatus fossa, your infraspinatus, and your teres minor tendons. Remember, the spine of the scapula divides the supraspinatus and infraspinatus muscles. And then in an anterior view, you've got your subscapularis muscle, which attaches to the lesser tuberosity. And you can see it also provides stability for this, which is your long head of the biceps and the long head of the biceps tendon. This is that schematic. This is your supraspinatus tendon, the most superior tendon in the rotator cuff. Then you have your infraspinatus tendon posteriorly and inferiorly, and then below that is your teres minor tendon, and then anteriorly you've got your subscapularis tendon. Other muscles around the shoulder that you will need to know include the deltoid, which is the big fan-shaped muscle. It's quite obvious when they point to it on the exam, and this lies superficial to the rotator cuff muscles, which we've talked about. You then have your teres major muscle, which lies beneath or inferior to the teres minor muscle. These two big muscles, you've got your trapezius, which again is quite straightforward on cross-sectional imaging, and your latissimus dorsi muscles. The rhomboid and levator scapulae muscles, you won't need to know for the exam, or I doubt they'll point to them in the exam. You then have your anterior chest wall muscles. You've got your pectoralis major muscle, which has a couple of heads, which you won't need to know for the exam, but just to be aware. Deep to that, you've got your pectoralis minor muscle, and then you also have your serratus anterior muscles overlying the lateral ribs, and these have quite an obvious appearance on imaging. This is a single image of the shoulder. This big muscle around the shoulder would be your deltoid muscle, and as you can see, there are several parts to it, which you won't need to know. Then you have your subscapularis muscle, your supraspinatus muscle, and your infraspinatus muscle, which we'll go through now on an MRI. This is an MRI of a shoulder, and a few key points just to show you. On this axial image, you've got your clavicle here, and then you've got your acromion here, and so this would be your acromioclavicular joint. Scrolling down, you've got this muscle here, and as I mentioned, the deltoid muscle is divided into different parts, but all you'll need to know is that it's called the deltoid muscle, and this goes across the entire shoulder, and it's the most superficial muscle. This process here, again coming from the scapula, would be your coracoid process, and then this would be your glenoid, and then your humeral head. This would be your greater tuberosity. Tubercle is, I think, what they say in America, but in the UK we'll say tuberosity. This would therefore be your lesser tuberosity. And as you can see, there's a groove between the two. So this would be your intertubercular or bicipital groove. And within that, this dark structure would be the long head of the biceps tendon. Remember, the glenoid is made deeper by the glenoid labrum. So this is the anterior part of the glenoid labrum. This is the posterior part of the glenoid labrum. When people dislocate their shoulder, for example, this area can be injured, is why it's clinically important. Going to the muscles, on the axial images, they can show you an image like this, and you'll need to know that actually this is quite superior in the shoulder because you can see the coracoid, and so this muscle here would have to be your supraspinatus, whereas if they show you an image further down, you can't see the coracoid process, and so you'd have to infer that this would be the infraspinatus muscle because it's further down, and then subscapularis is always within the subscapular fossa of the scapula. We'll go to some of the sagittal images now. I just want to show you, if they're going to show you this ligament, they'll show it to you like this. So this is the coracohumeral ligament. So between the coracoid process and the humerus here. And then this would be your coracoacromial ligament between the coracoid and the acromion here. Going to the bony anatomy, this would be the spine of the scapula here, and that would divide the supraspinatus and infraspinatus fossae. And so this would be the supraspinatus muscle, infraspinatus muscle, and then this would be your teres minor muscle. And remember, superficial to that would be your deltoid. This muscle here would be your subscapularis muscle, and then you can see these little tendon slips coming and attaching to this, which would be your lesser tuberosity. Let's go through the coronal anatomy. Again, you've got your clavicle here, so the distal end of the clavicle, your acromion here, and your acromioclavicular joint. You then have your humeral head, which is this. This would be the anatomical neck of the humerus. This would be your surgical neck of the humerus. You've got your greater tuberosity here. And then coming anteriorly, you've got your lesser tuberosity here. And you can see the subscapularis muscle fanning and attaching to the lesser tuberosity as well. And the labrum on a coronal image just looks like these little black triangles, as you can see here. This black triangle here, and then you can see it deepens the glenoid and helps with shoulder stability. Let's go through some cases now. So this is a sagittal view of the right shoulder. In the exam, make sure you say right shoulder, especially if they show it to you, because otherwise you'll lose half a point. So the main thing to do is orientate yourself. So you see little processes here. You've got this one and this one. You can see that this one articulates with this bone here, which is your clavicle. And so this would be your acromion and this would be your coracoid, which doesn't have a bony articulation. And so once you've orientated yourself, coracoid process, acromion process, your acromioclavicular joint. 13 would be your glenoid. So the reason why it's glenoid is because you can see this pear-shaped bone here projected through the humeral head. I think it's a little bit tricky, but because they're showing the edge of it, I think it's fair to say that this is the glenoid and not the humeral head. I think if they showed it was a humeral head, they'll make it more obvious. And then further down, 14 would be the shaft of the, again, right humerus. So this is an AP view of the left shoulder. They've got a line here, and that's pointing to the surgical neck of the humerus. B is pointing to this sclerotic ridge here, and as I mentioned, that would therefore be the lesser tuberosity of the humerus. D would be the acromion process of the scapula. You know it's the acromion process because it's articulating with the clavicle there. This is another Y view, and going back to what we just talked about, let's see what's articulating with the clavicle. And so this is the acromion, which they haven't pointed to, but they have labeled the clavicle. The joint between the two would be your acromioclavicular joint. C would therefore be your coracoid process. Remember, the most anterior bony process on the Y view. E, they've put this Y in the scapula, and that center would be the glenoid cavity. D, they've pointed to this entire structure here, which separates the supra and infraspinatus fossae, and so this would be the spine of the scapula. So this is an axial radiograph of the shoulder. These can be slightly tricky to orientate yourself with, but you just need to go back to those principles which we talked about. You try and look for a process which doesn't articulate with bone, which would be this. There's no articulation with bone. There's this bone which projects over it, but there's no joint there. So this would be your coracoid process. D would therefore be your clavicle. C would be the less tuberosity of the humerus. And this is quite tricky, but the subscapularis tendon comes like this, and then the tendon would attach to this, which is your lesser tuberosity. This is quite difficult, but remember this view, and if they point to this, it's your lesser tuberosity. A would be the glenoid fossa. You can see this cup here, which the humeral head articulates with, and therefore E would be the head of the humerus. Let's look at some MRI now. So this is the shoulder. This looks like the right shoulder. And actually, in the exam, I think you should say right, because you can see that the heart is not on this side, and so the heart would be over here somewhere. And so you have enough information to say that this is the right side. And the superficial muscle, superficial to everything, like we mentioned, is the deltoid muscle. The rounded black structure in the intertubercular groove would be the long-headed biceps tendon. This is a sagittal view of the shoulder, and we need to orientate ourselves. You see this broad bone here, and you see this small bone here. So you need to ask yourself which is coracoid and which is acromion. And you can see that this looks like the coracoid process. It's rounder compared to the flatter acromion. And so this would be anterior. So if we work out that this is the coracoid process, the tendon most superiorly would be your supraspinatus tendon, B would be your infraspinatus tendon, and then A would therefore be your teres minor muscle. C is your acromion, which we mentioned as well. This would be actually your coracohumeral ligament here. So actually this can be thickened and edematous in adhesive capsulitis. So if they'll show it to you, they'll show it to you like this. This is an axial view of the shoulder. It's the left shoulder. And you've got, let's just go through them. So you've got your subscapularis muscle here. You can see that it's in the subscapular fossa, which is the fossa deep as opposed to superficial. And then the tendon here comes and attaches to the lesser tuberosity, which is this little tuberosity here. So therefore B is the subscapularis tendon. C would therefore be the long head of the biceps tendon. It's quite obvious once you've seen a few what it looks like. D is the glenoid of the scapula, and then E is your infraspinatus muscle. Infraspinatus, it's infraspinatus, not supraspinatus, because you can't see the coracoid process, remember? And then that attaches to the greater tuberosity, and you can see some of the tendons coming here and attaching to the greater tuberosity. So this is a right shoulder arthrogram. You got the humeral head here, and you know it's an arthrogram because you get a little bit more fluid in the glenohumeral cavity, but you won't need to say that, I suppose, in the exam. A would be the greater tuberosity, where all these rotator cuff tendons, or some of them at least, attach. B is your acromion. This looks like where the acromion should be, and this is the subacromial space. Sometimes you get impingement here. C is your supraspinatus muscle. You can see that it's above the spine of the scapula, which would be here. This would therefore be your infraspinatus muscle. E is your inferior glenoid labrum. This triangular black structure here is what the labrum looks like. D would be, it says the right joint capsule, the right joint capsule. And yeah, it's pointing to this thin structure here, which is part of the joint capsule. They can ask you similar structures on CT as well. And don't get confused just because it's not MRI. They just go back to first principles. So anterior, posterior, the most superficial muscle in the shoulder would be your deltoid. You then have these two muscles here, your chest wall muscles. The most superficial one would be your pectoralis major, and then deep to that would be your pectoralis minor. And then E, this posterior muscle here, we're at the level of the humerus, so this isn't at the level of the rotator cuff. This would be where your triceps muscle would be. I think they won't ask you about the heads of the triceps muscle, but yeah, this would be your triceps. This is another arthrogram. You can see this contrast that they've injected into the shoulder. A would therefore be your glenoid. B B would be your subscapularis muscle. D, because we can't see the coracoid, would be your infraspinatus muscle. C is your long-headed biceps tendon, this little black structure that they're pointing to, and then E would be your anterior labrum. This is another arthrogram. You can see that they've given contrast and the joint is distended. Again, let's go through it quickly. Glenoid, humeral head. B is the trapezius muscle, and actually this is quite good because this would be your supraspinatus muscle, supraspinatus tendon, which is E, attaching to the greater tuberosity, but actually above it is the superficial muscle of the upper back, and that would be your trapezius, and then D would be your deltoid muscle, which is the most superficial muscle of the shoulder. A few more. So let's orientate ourselves first. This is the clavicle articulating with the acromion process, and then this is anterior then, so this would be the coracoid process. A is the most superficial muscle, it's superficial to this muscle here. So this is the entire muscle, so this would be part of the deltoid muscle. B would be the supraspinatus muscle. It's supraspinatus because it's being divided by this bone or part of the scapula, which would be on a different slice, but it would come like here, the spine of the scapula. So this would be supraspinatus. C would therefore be infraspinatus, and you see how the rotator cuff muscles are deep to the deltoid muscle. E would be the head of the humerus, and then D, as we mentioned, would be the acromion process. Orientating ourselves, this is anterior, this is posterior. A is, this is actually I think they're just pointing just inferior to the coracoid process. And yeah, so this would be some of the tendons attaching to the coracoid process. The two tendons that attach to the coracoid process are the short head of the biceps tendon and the coracobrachialis tendon. I think this is a bit confusing where it's exactly pointing to, but just know those two tendons attached to the coracoid process. B is the anterior glenoid labrum. So glenoid fossa, this black triangular bit would be the labrum. C would be your infraspinatus muscle. You can't see the coracoid that well, and so you're quite far down, and you can see that this is then attaching to the greater tuberosity here. D would be, actually it's your middle glenohumeral ligament. This attaches often to the neck of the scapula here. I think if they showed this, it would be a little bit harsh. It's quite subspec, but just know that this is the middle glenohumeral ligament. And then E, lastly, the most superficial muscle of the shoulder is your deltoid muscle. This is a good example of just orientating yourself. So this is a coronal MRI of the right shoulder. You then need to ask yourself, what is this? Is it infraspinatus or is it subscapularis? It's subscapularis just because of the orientation of things. So A is subscapularis, which is attaching to this bony bit here, which is your lesser tuberosity. The infraspinatus, remember, attaches to the greater tuberosity, which is around here, on a different slice, of course. B is therefore your coracoid process. C is the distal end of the clavicle, coming across here. I think if you just said clavicle, that would be plenty. D is the biceps brachii muscle, and then E is your axillary neurovascular bundle. Let's go to the elbow joint now. So this is an anterior and this is a posterior view of the elbow. There's a few structures to know. This is the humerus, this is the radius, and this is the ulna. Remember, this is all about anatomical, you've got to imagine this in the anatomical position. So this would be lateral and this would be medial. The head of the humerus, the neck of the humerus, and the shaft of the humerus. Then you have the radial tuberosity, of the radius, all of those structures. And then you have the radial tuberosity. The capitellum, which is part of the humerus, articulates with the radial head there. You then have the trochlea of the humerus, which sits within the trochlear notch of the ulna. You have the lateral and then the medial epicondyles. This is a posterior view, and this is your olecranon, which is the part of the elbow, which is the most prominent posteriorly. You then have, these are similar images to this. So this is just the humerus. You have your trochlea, where which sits inside the trochlear notch, your capitellum, and then all the structures which I've just mentioned. Remember, think about these bones in the anatomical position, and your hand is out like this in the anatomical position. So this is lateral, and then this is medial. So the lateral bone is your radius, and the medial bone of your forearm is your ulna. So we'll go through the main things they can ask you on an X-ray. This is a AP view elbow X-ray. 1 is your humerus. 2 is your lateral epicondyle. This is where your common extensor tendon is. 13 is your medial epicondyle, where the common flexor tendon origin is. 14 is your olecranon fossa. You can see that this is the olecranon process 12, and that sits within this, which is your olecranon fossa. 3 is your capitellum, which articulates with the radial head at the radiocapitellar joint, which is 4. You can say radiocapitellar or radiohumeral, both are correct. 5 is your radial head. 6, where it sort of tapers in, is your radial neck. 9 is the radial tuberosity. This is where the biceps tendons attach. 7 is your radial shaft, and 8 is your ulnar shaft. There are a few ligaments in the elbow that help with stability. They're all important, but most of these are quite subspecy. The one that they can show you quite easily in the Part 1 exam is the annular ligament. It's got quite a typical structure, and that connects the ulna and the humeral head and helps with stability. You then have the collateral ligaments. You've got the radial collateral ligaments on the radial side, and then the ulnar collateral ligaments on the ulnar side as well. As I mentioned earlier, the coracoid process has attachments to both the short head of the biceps and also the coracobrachialis muscle. The brachialis muscle itself, they can show you. This is the deeper muscle to the biceps brachii muscle, and that starts from the humeral shaft and then attaches onto the ulna. And remember, the biceps brachii muscle attaches to the radial tuberosity. And then you've got your triceps muscles. I don't think they'll ask you the different heads. Just remember it attaches to the olecranon. This is an anterior view of the elbow, and the muscles that I've underlined are probably fair game. The big bulky muscle at the lateral aspect of the forearm is your brachioradialis muscle. You then have, on the medial side, the big bulky muscle is your pronator teres. Remember what I mentioned, the biceps brachii muscle is the most superficial anterior arm muscle, and then deep to that, you've got your brachialis muscle. At the wrist, you've got something called pronator quadratus. This is a posterior view of the elbow. This muscle here is your anconeus. It's got quite a typical look on an MRI or cross-sectional imaging, which I'll show you later. And then you've got your triceps brachii muscle as well, which has several heads, 3 heads, but I don't think you'll need to know them. Then you have the supinator muscle, which has, again, quite a typical appearance on cross-sectional imaging. This is a sagittal view of the elbow. This is an MRI, and just as I mentioned, you've got your biceps brachii, which is the most superficial muscle of the upper arm. You've got your brachialis muscle, which is deep to that. You've got your triceps muscle, and the tendon attaches to the olecranon process. Your brachialis muscle comes down like this and attaches to the ulna, and then your biceps attaches to the radial tuberosity. again, this is an X-ray of the forearm. You've got the head of the radius here, the neck, and then the shaft. The only other thing you'll need to know is the radial tuberosity. All the little structures here that they've labelled, you probably don't need to know. You will need to know actually the coronoid process of the ulna. This is again repeating those muscles which I mentioned. The big muscle on the lateral aspect of the forearm is your brachioradialis, and then medially you've got your pronator teres, and then the other forearm, the other flexors, which they can point to, but I think it would be quite harsh, and it's quite hard to discern the different muscles on just a static image. So I think all these other smaller ones, they probably won't test you on, okay? Let's go through an MRI. So we're at the level of the humerus. You know, we're at the humerus because there's only one bone here. And when we come down, the medial epicondyle is this bony prominence here. And then you've got your lateral epicondyle. Remember, your medial epicondyle is where the common flexor tendon originates, which is this. And then your lateral epicondyle is where your common extensor tendon originates, okay? In terms of muscles, you've got your biceps brachii muscle, and then your brachioradialis muscle, and then you've got your triceps brachii, or just triceps muscle. If we follow biceps down, you see it coming down, you see these tendons, and they attach here to the radial tuberosity. And then you've got your brachialis muscle and then tendon here. And then that attaches to the ulna. Further in the forearm, as I mentioned, laterally you've got your big bulky brachioradialis muscle, and then you've got your pronator teres, and then the other flexor muscles, which, as you can see, it's quite hard to sort of tell exactly which ones are which. And so honestly, I don't think they'll ask you, but they could ask you about pronator teres. This is another quite typical looking muscle which they can ask you about, and this would be your supinator muscle. And then this is the anconeus muscle which I mentioned. It's got quite a typical look and is between the radial head and the ulna. In terms of ligaments, you've got the annular ligament, which would be this sort of black structure coming off here. There's also something called the lateral ulnar collateral ligament, which again is quite subspec and you won't need to know for the exam, okay? Let's look at a coronal view. So you've got, let's look at the bony anatomy. You've got the humerus, radius, and then ulna. So this is lateral, this is medial in the anatomical position. And then you've got these different fossae, which they might try and trip you up on. So this would be the olecranon fossa. You're slightly further back in the scan at this level, and so the olecranon process would sit within this fossa on elbow extension. And then if we come more anteriorly, I don't think that, maybe it is labelled, but you would have your coronoid fossa as well, but it's hard to see on a coronal image. You'll see it better on a sagittal. And then you've got your capitellum here, you've got your radial head here, you've got your olecranon process here, and then you've got your trochlea and trochlear fossa as well around here, which is better seen on the sagittal. This is what the collateral ligaments look like. So this is your radial collateral ligament between the humerus and the radius, and then you've got your ulnar collateral ligament here, which has different bundles. But yeah, ulnar or medial collateral ligament. This is what they look like. So if they point to like a black structure which is deep to the tendons, remember ligaments are often deep to tendons. Then it would be your radial and ulnar collateral ligaments. If we now look at a sagittal view, we can see those fossae which I mentioned. So this would be your olecranon fossa, this would be your coronoid fossa, this would be your coronoid process, and this would be your electron process. Remember, this is the trochlea of the ulna, and then this is the trochlea fossa of the ulna, and then this would be your trochlea of the humerus. Remember, on the sagittal X-rays, you have a figure of 8 sign here, and if you have a fracture, you get elevation of the fat pads. These are the fat pads. So this high T1 signal area here would be your anterior fat pad, and then this would be your posterior fat pad, and these can be elevated when you have a joint effusion. So let's look through some cases. So this is an AP elbow X-ray. The main thing to do is orientate ourselves, so we know that this is radius, this is ulna, this is humerus. Let's start with A. Because this is radius, this little bulge here would be your radial tuberosity. B, they are asking what sort of structure would connect this area, and that would be your annular ligament. C, between the radial head and the humerus, would be your capitellum. D would be the metaphysis of your humerus, and then E would be the the medial epicondyle, which is where your flexor muscles originate. This is a sagittal view of the elbow. They're pointing to the anterior part of the humerus. This is your anterior humeral line. You can use this line to see if there's a supracondylar fracture. Remember, the line should pass through the anterior 1/3 of the capitellum, which is here. B is your olecranon fossa. Remember, it's not the best example, but there's often like a figure of 8 here, and the fossa at the back here, where the olecranon sits on with elbow extension, is your olecranon fossa. C is therefore this would be your coronoid fossa anteriorly there. E is your coronoid process itself, and then D is your olecranon process. You can see that this is a pediatric elbow radiograph because the growth plates have not fused yet. There is a way of remembering when the growth plates fuse. There's an acronym called CRITOL, which you should look up for the exam as well, but we won't go through it in this lecture. A is the radial head, or radial epiphysis, radial head epiphysis, should I say. B would be the epiphysis of the capitellum. C would be the epiphysis of the lateral epicondyle. D would just be your medial epicondyle. You can actually see a faint growth plate there, so you can call it the epiphysis of the medial epicondyle, and then E would be the epiphysis of the trochlea. Let's go through some MRI now. So the main thing to do here is orientate yourself. You know, the humeral head, the radial head is round, and so this would be the radius, this would be the ulna. And so D would be the proximal radio-ulnar joint. Remember, there's a distal radio-ulnar joint at the wrist as well. A would be your one of your flexors, because this is at the medial forearm. So this is actually flexor carpi ulnaris, but I think it would be difficult to show you this in an exam. I think it's quite difficult, but yeah, this would be one of the flexor muscles. B would be your radial nerve. Your radial nerve is in this area, and yeah, it's surrounded by fat, and it's on the radial side, and that's why it would be the radial nerve. C is your biceps tendon. As it comes more distally, or attached to the radial tuberosity of the radius. And remember, this is what they do like to show you. E would be your anconeus muscle, and it's got quite a typical look to it, doesn't it? So we've got to orientate ourselves. Where are we? What's medial? What's lateral? This is your ulnar nerve, and actually if you feel it on yourself on the medial side of your elbow, where there's a little dip, if you press too hard, or if you sort of bang it against something, you get tingling down the inside of your forearm, down to your little finger and ring finger, and that's because the ulnar nerve supplies this area. so this structure deep to this ligament here is your ulnar nerve. And so we know this is medial. So then this would therefore be the medial epicondyle. B would be your, it's pointing to the tendon here, but this would be the lateral epicondyle here. And so laterally, remember, it's the common extensor tendons that originate from there. A would therefore be your common flexor tendon origin. And yeah, C would be the olecranon process of the ulna. This is a coronal view of the elbow. A would be the coronoid process of the ulna. I think it's quite difficult to say it's pointing to the ulna clearly because this is the radial head. You got to, I think it's a bit harsh to show you this, but it's quite anterior, and the most anterior process of the ulna, remember, is the coronoid process, which would then sit in the coronoid fossa. This isn't a true oblique. It's like true coronal. It's a coronal oblique. So C is not the coronoid fossa, it's the olecranon fossa. It's a little bit tricky, but yeah, the big fossa is the olecranon, and this looks quite big, and so maybe that's a way to remember that would be the olecranon fossa. B, because we're quite lateral, would be your radial collateral ligament. You can see this ligament attaching from the humerus to the radius there. And then D, because we're quite medial, these would be a flexor muscle here, and this is flexor carpi radialis, but again, I think it's quite harsh if they showed you this in the exam. This is a sagittal view, and I think these are quite easy once you've seen a few now. So B is posterior in the elbow, so this would be your triceps muscle attaching to the olecranon process. A is the most superficial muscle, so this would be your biceps. C would be your brachialis. Remember, olecranon process, coronoid process, olecranon fossa, coronoid fossa there. So they're showing you an image of the humerus here, and then you've got to ask yourself what's medial and what's lateral. Remember, your brachial artery is medial. This is where you can feel the pulse on the inside of your arm, and then you've got different veins around it. Remember, in the fat, you have the superficial veins of the arm, and I put a lecture out for these, but laterally you'd have your cephalic, and medially you'd have your basilic veins, and so D would be your brachial artery, and C would be your brachial vein. This is what the artery looks like on a MRI. It's just a bit more rounder, a bit more crisp compared to the vein, although, yeah, it can be a little bit confusing. And then B would be your humerus. Okay, let's go through a couple more. This is a axial short axis view of the elbow. And remember, the main thing to do is orientate yourself. Where are we? This looks like the anconeus muscle. It's quite, when you get your eye in, it just looks like that. And then you've got to ask yourself, where is the ulnar nerve? That is the ulnar nerve, and then it's got that ligament overlying it. You've got your A would therefore be your medial epicondyle, where the common flexor tendons originate. C would be your olecranon, and then E would be your lateral epicondyle, where the common extensor tendon originates. Let's look at this one. A, you can see there's a tendon attaching to this bone here. This is rounder and it looks like the radius. And also around the radius, you've got this quite distinct muscle, which is your supinator muscle. So A would be the tendon of the biceps brachii muscle. B would be your supinator muscle. C would be your ulnar. D would be your anconeus. You're starting to get your eye in. It looks quite a typical muscle at the back of the elbow. And then E would be your brachioradialis muscle. Remember the big fleshy muscle at the lateral forearm. Okay, let's go through some hand and wrist anatomy now. So you've got your carpals, you've got your metacarpals, and then your phalanges. They can definitely ask you which bones are which. And there's a good way to remember, which I got taught, which is starting from proximal and then going distal. You've got your scaphoid, your lunate, your triquetrum, your pisiform, your trapezium, your trapezoid, then capitate, and hamate. And the way to remember that is some lovers try positions that they can't handle. And it's quite intuitive from that. And then the way to remember trapezium versus trapezoid is remember trapezium, is under the thumb, so this is the thumb, and so trapezium is under the thumb. This is an X-ray of the same area. You've got your distal radius, you've got your ulna. Remember the radius and the ulna, the little pointy bits at their margins are your styloid processes. So if they're pointing to this little bit of the radius, that's your radius styloid process. And then this would be your ulnar styloid process. And then you've got your carpal bones here. So scaphoid, lunate, triquetrum, and then underneath that, volarly, you have your pisiform. Trapezium is under the thumb, trapezoid, capitate, and then hamate. And then you've got your metacarpals here, your phalanges here. Remember, there are 3 phalanges, proximal, middle, distal, of the 4 fingers, and then of your thumb you only have 2. And so you'd have your proximal interphalangeal joints here, and then your distal interphalangeal joints here. But remember, at the thumb, you only have an interphalangeal joint. And then you have a couple of sesamoids as well at the thumb. There are lots of small intrinsic muscles of the hand, and I think the important thing to remember is you don't need to know them. All you'll need to know for the Part 1 exam is at the ulnar margin of the hand, they're called your hypothenar muscles, and then at the thumb area, they're called your thenar muscles. Hypo is smaller than just thenar, and so that's the way to remember it. You've got more intrinsic muscles of the fingers and hand, and these are like your interossi and lumbrical muscles. Again, I don't think they'll ask you about them. You then have your carpal tunnel structures. They can definitely ask you about these, and it's important to orientate yourself. Okay, so this is an axial view. This is the volar margin of the wrist. This is the dorsal margin. Volar just means the palmar side, so towards the palm of your hand. And then dorsal is the other side. The flexor retinaculum, which is this pink structure here, attaches from the hook of the hamate to the trapezial ridge. Okay, and that is your flexor retinaculum. And then these are your carpal tunnel structures. Your median nerve is the nerve that gets compressed and irritated in carpal tunnel syndrome. So it stands to reason that that is deep to the flexor retinaculum, which is sometimes thickened and causes compression of it, and so you get carpal tunnel syndrome. You then have flexor digitorum, superficialis, and profundus tendons. The superficial tendons are superficial to the deep tendons, and so that's a way of remembering it. And these then go out into the fingers and help you flex your fingers. And then just at the thumb, you have something separate. You've got your flexor pollicis longus tendon, which is the most radial tendon within the carpal tunnel. And this flexes your thumb, opposable thumbs, and that's why, presumably, evolutionarily, this helps us with opposable thumbs. This is an MRI of that same area. Remember, the hamate has this distinctive hook. You see the trapezium here, and you've got a ridge here, and that's where this black structure, the flexor retinaculum, attaches between the two. And then you've got your carpal tunnel structures, you've got your flexor digitorum superficialis tendons and your profundus tendons as well. And then you've got your flexor pollicis longus tendon towards here. And then this grey blurry structure here would be your median nerve. The other area or thing to look at is this here, which would be your ulnar nerve and your ulnar artery, and those aren't within the carpal tunnel. And so, yeah, those are outside the carpal tunnel. This is the same thing. You've got your carpal tunnel structures here, you've got your superficial, and then your profunda tendons, which go out into the fingers and help with flexion. You've got your median nerve, and then you've got your flexor pollicis longus tendon as well, which goes out into the thumb. And yeah, remember the ulnar artery and ulnar nerve are superficial to the carpal tunnel. You then have the wrist extensors, and they can ask you this, and I think as an SC1 it can be quite difficult, but we can go through them. There are 6 compartments in the extensor, in the wrist, extensor compartments in the wrist. And the first one has the adductor pollicis longus, extensor pollicis brevis, extensor carpi radialis longus, extensor carpi radialis brevis, extensor pollicis longus, and then extensor indicis and extensor digitorum tendons. You then got your extensor digiti minimi, and then your extensor carpi ulnaris tendon. And the way to remember this is abductor pollicis longus, so it goes longus, brevis, longus, brevis, longus. And you have to orientate yourself by finding this, which is Lister's tubercle, which is this little tubercle here, which separates the second and third extensor compartments. And then extensor carpi ulnaris is towards the ulna, and so that's relatively easy to remember. The fourth compartment with all the extensor tendons towards the fingers is the extensor digiti tendons, and that's relatively easy to remember. But then the trickier ones would be your extensor pollicis longus, which is just on the ulnar side of the Lister's tubercle, and then your extensor digiti minimi, which is between the fourth and the sixth extensor tendons. They can show you these, so maybe it's one of those ones to look at last minute, and not last minute, but look at in the last couple of days just to refresh your anatomy for the exam. Because yeah, if you're not doing MSK subspec, they are quite difficult to remember. And even if you are, they're pretty difficult to remember. This is an MRI of those same structures which we've talked about. So we try and find this, which is Lister's tubercle, and then we take it from there. So you've got your abductor pollicis longus. So this is your first compartment. So abductor pollicis longus, extensor pollicis brevis, so longus, brevis, and then longus is your extensor carpi radialis longus, and then extensor carpi radialis brevis. And then on the other side of Lister's tubercle, in the third compartment, you've got your extensor pollicis longus tendon, and then your extensor digitorum tendons in here. You've got this tiny little tendon here called your extensor digiti minimi, which is the fifth extensor compartment, and then you've got your extensor carpi ulnaris tendon here, your ECU, which it's quite distinct, and it's all the way on the ulnar side, and so that's how you remember that one. And then you've got your flexor tendons here as well. Let's look at an MRI. So this is that same thing which we've just gone through. I won't go through it again, but first, second, third compartment. Remember, the Lister's tubercle divides the second and then your third extensor compartments. You've got then your fourth extensor compartment, your fifth, which is here, and then your sixth, which is here, so your ECU tendon. Then finding the carpal tunnel structures again. So this is the distal forearm here, going towards the hand here. And then you've got this typical image here, your carpal tunnel structures. You can see this black line here, which is your flexor retinaculum. You've got your hook of the hamate, and then you've got your trapezium, and this is the ridge, and that's where the flexor retinaculum attaches. Towards the thumb, you've got your flexor pollicis longus tendon, as you can see here. It's going down, down, and going towards the thumb. So opposable thumbs. And then you've got your superficialis tendons, which go out towards the fingers, as you can see here, and help with finger flexion. And then you've got your deep ones as well. And then remember, your ulnar nerve and your ulnar artery and vein are superficial to the flexor retinaculum. In Guyon's canal is what this is called. And then they can show you an image like this. And all these muscles, they do have their own names, but just remember, like I mentioned, you've got your thenar muscles, which are these, and then you've got your hypothenar muscles, which are these. Let's go through some cases. So this is an AP radiograph of the wrist. A is your scaphoid. So B would be your lunate. So some lovers try positions that they can't handle. It's quite straightforward once you have an acronym. C is your radial styloid process. Remember, if they showed you sort of that little protuberance here, you should call it the styloid process, and that's the way you get full marks. The ulnar styloid process is here. This is the distal radial ulnar joint. remember we spoke about the proximal radial ulnar joint. Remember distally, the radius is the biggest bone that articulates with the proximal row of the wrist of the carpus, and then at the elbow, the ulna is the biggest bone that articulates with the humerus at the trochlea. This is an X-ray of a pediatric patient, and you just got to think about the different carpal bones in the same way, using the same acronym. Okay, so coming from radially, B would be the scaphoid, this would be the lunate, and so A would be the triquetrum. Okay, you then have these, which are the epiphyses. This would be the epiphyses of the index finger. E would be the physis, because it's showing the line between the epiphyses and the metaphysis. So this would be the physis of the fifth metacarpal. Okay. Interestingly, the growth plates of the of digits 2 to 4 are distal within the metacarpal, but actually of the thumb, it's proximal here. I don't think they can trick you in the exam, but it's interesting to know. So going through these quickly, we know that this is scaphoid, this would have to be lunate, triquetrum, pisiform, this would be the hamate. This structure here, which is the sclerotic area here, this would be the hook of the hamate, which is you're catching it en face, and so that's why you can see it like this. E would be the metacarpophalangeal joint of the ring finger. D would be the proximal phalanx of the index finger, and then C would be the ulnar stylo process. So let's now look at a lateral view of the wrist. You've got the most important thing to do is orientate yourself. This is the volar margin, and this is the dorsal margin of the wrist. Volar basically means palmar, so this is the palm of the hand, this is the back of the hand. This is an area which can be quite confusing. So you've got a couple of overlapping bones here. You've got your scaphoid and you've got your pisiform. The way to differentiate the two is not which one is anterior and which one's posterior, but it's which one is then connected down to bone here. And the one that's connected would be your scaphoid, which is a big bone that sort of comes around like this and almost looks like a duck, like a rubber duck you'd have in the bath. Sometimes people who get a triquetral fracture, they get a little fragment of bone here, and then the sign that this is called is the pooping duck sign. The other bone in this area is the pisiform, which is that round bone just at the volar margin of the triquetrum. And yeah, depending on how the wrist is angulated, one of them is in front and then the other one is behind. But that's not always the best way to differentiate the two. The other structures labeled, this is the ulnar styloid process. You know that this is the ulnar because this bone is quite small compared to this larger bone, and this would therefore be the ulnar styloid process. B we know is the pisiform. E would therefore be the scaphoid. D would be the lunate. The lunate is this moon-shaped bone here that sits within the radial notch. And then C would be the capitate. This is a pediatric X-ray. A would be the first metacarpal epiphysis, so this is that epiphysis of the thumb, which I mentioned before. B would be the capitate, because it's the distal row, and it's the middle bone. C would be the hamate. D would be the triquetrum, and yeah. E would be the distal radius epiphysis. Now let's look at some MRI. Just to orientate ourselves, this would be the volar aspect of the wrist, and this would be the dorsal aspect, and this looks like the carpal tunnel structures that we just saw. This is towards the little finger, this is towards the thumb. A would therefore be your hypothenar muscles. B would be your ulnar neurovascular bundle. You can see that this is superficial to the flexor retinaculum, which is C. D would be the contents of the carpal tunnel. So you've got superficial and deep flexor tendons, you've got your abductor pollicis longus, sorry, flexor pollicis longus, and then you've got your median nerve there. This is a little bit distal to that area, and you just got to orientate yourself. This is a smaller muscle than this, so these would be your thenar eminence or thenar muscles. A would be your it's your palmar aponeurosis, which is more distal than the flexor tendon. I think it would be difficult if they showed you this, but if you showed this and he said, sorry, flexor retinaculum or palmar aponeurosis, you'd be correct. B would be the tendon of the flexor digitorum superficialis for the middle finger. This would be the thumb, index, middle finger, and then this would be going towards the middle finger, so that's what that would be. E would be the lumbrical muscles of your finger, which I'd mentioned before, and I think it's unlikely they're going to ask that, but the muscles between the fingers would be your lumbricals, and then D would be your palmar digital arteries as well. There's a structure between the ulna and the proximal row of the carpus, which is called your triangular fibrocartilage complex. This is a relatively complex structure, but all you'll need to know in the exam is to call this area your TFCC, or triangular fibrocartilage complex. This is a sagittal view of the wrist. Let's see where we are. So this would be the radius. This moon-shaped bone would be your lunate. D would therefore be your capitate. And then E would be the base of your third metacarpal. Remember, on your hand, the middle bone is your capitate, and that articulates with the third MCP. You then have your superficial and deep flexor digitorum tendons, and this again would be for your middle finger. You can sort of see it going down there and would be going towards your middle finger. So let's start proximal and then go distal. C would be your lunate. You can imagine this would be your scaphoid, partially imaged on this slice, then lunate, and then pisiform. Pisiform is rounder than your triquetrum, and so that's the way to sort of remember it. Pisiform is also more on the volar aspect, so this is more at the flexor side of the wrist, and so A would be your flexor digitorum tendons. I think it's hard to tell if they're superficial or deep, but yeah, these would be your flexor digitorum tendons, and then E would be the tendon of the flexor pollicis longus coming and going and attaching to the thumb phalanges. This is the extensor. They're pointing to tendons in the extensor compartment of the wrist. Remember, your first extensor compartment, it goes longus brevis, so this would be your abductor pollicis longus tendon, and then this would be your extensor pollicis brevis tendon as well here. They're not as well separated, but yeah, that's what this is, your first compartment. E would be your extensor carpi radialis longus, and then C would be your extensor carpi radialis brevis. Remember, longus brevis, longus brevis, longus. Remember, D, it's on the ulnar side, and so that would be your extensor carpi ulnaris tendon, and then B would be your ulna. So we're at the carpal tunnel again. It's a different orientation to what I've shown you before, but we can imagine it. So this would be your flexor retinaculum. So B would be your flexor retinaculum. A would be your flexor digitorum profundus tendons, because they are deeper to the superficial ones. C would be your flexor pollicis longus tendon going out to the thumb. And then D, because it's outside of the flexor retinaculum, would be your ulnar artery and nerve. The artery is this black structure. It's a flow void, so that's why it's black. And then here would be your nerve, and then E would be your median nerve. It's not the same intensity as the tendons, and yeah, that's where it is. This is a coronal image of the hand. As I mentioned, between the ulna and the proximal row, you have your triangular fibrocartilage complex, which is this. D would be your part of the scaphoid-lunate ligament. So this is your scaphoid and this is your lunate, and there are ligaments attaching the two, which can be torn in trauma. this area is called the interval. The space between the two is called the interval. And so that if this was an X-ray, you could probably call it scapholunate interval. But if it's pointing to like a black structure, this would be your part of your scapholunate ligament. There are 3 different parts to it, but you won't need to know that for the exam. B would be your trapezium because it's under the thumb. C would be the proximal phalanx of the thumb. Remember that it's got a proximal and distal. It's only got 2. And then E would be your capitate. Okay, let's try and picture where we are. Is it flexor or is it extensor part of the wrist? It looks like the flexor part of the wrist because we're quite towards the volar wrist, because you can see this bone here, which is your pisiform, which is rounder compared to, for example, your triquetrum. And also the way the tendons are in this, it doesn't look like the extensor compartment tendons where there are 6 compartments. These are all together, so these would be your flexor digitorum tendons. On the ulnar side, you've got your hook of the hamate, then you've got your trapezium here, and then you've got your first metacarpal bone. B would be the radial artery. Again, it's got a flow void through it, i.e. it's dark. Don't mix it up for a tendon, but just think about the anatomy. This is where you do your radial artery sampling in patients. And then this last image, it involves the elbow and the hand, and yeah, we can just work from first principles. This big bone at the wrist would be your radius, then therefore this will be the ulnar. So coming back up, we can see this here, so that would be your radial tuberosity. Remember, the articulation between the radius and the humerus is your radiocapitellar joint, so this would be the capitellum. E would be your trapezoid. Remember, trapezium would be a little bit here, but actually trapezoid is under the second metacarpal. So trapezoid, capitate, C would be your hamate. And then lastly, D would be the proximal phalanx of the thumb. So that's everything. I hope that was helpful. And yeah.